Good evening, sir. Today I'm presenting a case of a 64-year-old woman complains of pain over the right knee more than the left for the past 2 years, and for the past 6 months it's become worse. And now for the past 2 months she needs assistance while walking. Known case of diabetes and hypertension and under control. So she has a pronounced valgus present, a windswept deformity. She's having tenderness over the lateral side. The patellar glide, when we are trying to move, it's painful. The range of movement, we are able to correct the flexion position of 20 degrees to neutral while she's supine position. But it's not correctable, as in it just gives a yield, but it doesn't, both in varus and valgus test, there's no instability. This is her walking video. When she's having a thrust on the lateral side with no opening on the medial side, and she requires assistance while walking. This is her clinical x-rays. So we're speaking about the right knee. So we can see the sclerosis and the reduced joint space on the lateral side. You can see a valgus deformity somewhere more than around 15 degrees on the right side with severe patellofemoral changes. The medial side is opened up and you can see the widened joint space. Yet we can see some osteophytes on the medial side. And the lateral view also, we can see more of a central, not much of hypoplasia is visible of the lateral femoral condyle in the lateral X-ray. So these are the whole length standing images of the patient. So it's valgus of 17 degrees comes under type 2. When we draw the function, the mechanical as well as the anatomical axis, we can see that her MPTA is 96, LDFA is 80, and the valgus cut angle is 5 degrees and comes under the CPAC 3. So this is on how the grading is done, and this tells the posterolateral structures which are in question. So the challenges that I had in mind are: what is the approach? What are the soft tissue releases required? Bone cut alterations which are needed, the choice of implant, how to assess the MCL, and patellar tracking. I'd like one of you all to share some input, sir.
Okay, I'll get the ball rolling. Approach, I will stick to usual medial parapatellar, midline incision, medial parapatellar. There are a few surgeons who take to lateral, but I wouldn't, and not for this case. It's not much, around 15 to 20 degrees. We can easily manage with medial parapatellar, and only thing is don't do a very broad medial release. Just go maybe anterior 1/3, not even up to the middle of middle of the tibia. Just do a very mild release on the medial side for exposure, and that's how I will approach this knee. Anybody wants to take a different call, please speak up.
Tarun, is the deformity rigid or what it is like?
Sir, it is a rigid deformity, sir. No yield. Even after anesthesia, I tried it. There was no yield, sir.
Yeah. In rigid deformity, it is 17 degrees, like what you said. So, according to literature, if it is more than 14 degrees, especially when it is rigid, if we correct, the chance of lateral popliteal nerve stretching is there. So nowadays, what I have started doing is prophylactically we release the lateral popliteal nerve and free it up in especially rigid valgus knees. That helps us in correcting the soft tissue releases also, because lateral soft tissue releases, when we do with the 11 blade or spinal needle, whatever, we will be hesitant to do the releases liberally on the lateral side, like what we do in the medial side, because of concern of lateral popliteal nerve injury. But once we prophylactically free the lateral popliteal nerve through a separate incision, we can liberally release the soft tissues whichever is tight. So that is as far as the soft tissue release is concerned, and prophylactic lateral popliteal release will make our life easier, because we won't know which knee will go into nerve palsy. That is another thing. As far as bone cuts are concerned, I will go with the measured resection as far as valgus knee is concerned. I will not go parallel to the tibia like we do for the varus knee.
Okay, sir.
Those are for different reasons. And assessment of MCL, we can assess the MCL on table. In your case, it is not overstretched, and we can manage it with the primary knee as much as possible. And since we do measured resection, like what I said, patellar tracking, there is a 60-70% chance we may get away with the normal patellar tracking. Only if we go parallel to the tibia, you may internally rotate the femur, and in that case, patellar tracking may become a problem.
So, and one more doubt that I had, sir. How useful is the robotic in this case in terms of registration of the lateral femoral condyle hypoplasia, sir? Is there any change that you would
Yeah,
do, or once after you release it, or what axis will you take while keeping the rotations?
See, for all my cases, I take epicondylar axis also for registration.
Okay,
Okay. Now, condyles, you are going to map the condyles. Whether it is hypoplastic, the actual condyles you are going to map. Only thing is, when you put the tensioner into the gaps, in the flexion gap, the lateral condyle is deficient in my valgus knee. That is why in valgus knee, probably when I share my screen, I can show that the tensioner has a button, especially in valgus knees. When the condyles are deficient, you can use that button to open up the gaps. When I tell, it may look little complicated, but this is how
okay,
it has to go in a valgus knee. The deficient condyles has to be opened up.
okay,
If you don't open up, then the femur, you will take the cuts in internal rotation.
okay,
Once you open up the lateral condyles, it will automatically go into external rotation. It will favor the patellar tracking. I
okay.
don't know how much you are able to understand. With pictures, we can make it little more.
Sure, sir.
Um, yeah,
Yeah, I'm able to get it, sir. What you're saying. I think next when you share, it will be better,
see,
sir.
it's very simple. In a valgus knee, you are not cutting the lateral condyle. You are just
Yeah.
shaving the lateral condyle, distal condyle, and the posterior
Yes,
condyle. You
yes,
are
sir.
just shaving it. If you are over cutting it, you are going somewhere wrong. It's
Yeah,
as simple as that.
sure, sir.
Anyone
So
has experience with lateral epicondylar osteotomy like that, sir? Anyone?
I have done one before, but once we started doing this prophylactic lateral popliteal nerve release, the soft tissue release which we do with 11 blade is more than enough. I don't think lateral epicondylar osteotomy will be needed, but we need some more time to study this.
But unfortunately, in rigid cases, although the release is done, you will end up getting proper balancing only with epicondylar osteotomy. If it is giving way, in the sense that if it is correctable under anesthesia, the chances of us releasing the soft tissue and correcting is higher. But when it is so rigid, like what Tarun is saying, I would prefer doing an epicondylar osteotomy. I would not release tissue after tissue. I will not be cutting the popliteus. I won't be touching on the LCL. I would rather just do an epicondylar osteotomy, the whole bunch, just posterior and inferior, and fix it up with 2-3 screws, and I'm fine with that. The fixation.
I don't entirely contradict Dr. Armum sir's views. I'm just telling that by releasing the popliteal nerve prophylactically, we have a little more advantage in soft tissue
Yes,
release. That's all.
100%. See,
That's all.
because popliteal nerve is, you have to be very careful. You don't need a foot drop post-operatively. So prophylactically releasing in such rigid cases is always a very, very good thing to do. I'm not contradicting that at all. I'm just saying for the ease of the surgery, instead of going one tissue after the other, releasing it step by step. When you're doing the epicondylar osteotomy, it comes as one whole chunk, and the integrity of none of the soft tissues are hampered, be it the LCL or the popliteus. It's all still fixed, and it is going to function later on, instead of us cutting the soft tissue and letting it fibrose. That's my point. That's what I'm trying to drive in.
Another thing, Dr. Dhanashekhar Raja, he's to do the lateral parapatellar arthrotomy. I don't do it. In this case, probably more fixed valgus. Actually, his threshold is 15 degrees valgus, fixed one. And that will ease the patellar tracking also somewhat. You not do releases, fixed valgus deformity.
No, I didn't get your point, Mithun. Can you
Illa sir,
repeat?
if you go to a lateral parapatellar arthrotomy in fixed, if the valve
Tarun, can you show the pre-op X-ray,
yes,
Tarun? The long
Yes, sir,
leg.
sure, sir.
invariably the patellar tracking also there will be issue. So if you do a lateral parapatellar arthrotomy, it will be easy to release the lateral approach the lateral structures, and then your patellar tracking also will be better.
One more question I just wanted to interrupt here. Rajkana sir, Armu sir, in this particular case, preoperative planning, do you think all this kind of epicondylar osteotomy is required in this case?
No, in this case, I don't think it will be required. Especially
Definitely.
when you do the nerve release, you can liberally see.
And
epicondylar
for
osteotomy
this
is
type 2, Dr. Rajkana, for this type 2, would you do a population nerve release?
no, he is telling it is rigid and it is 17
No,
degrees, which is more than 14
still,
degrees.
you could see the exaggerated the valgus, the amount of medial opening you could see. Definitely, whatever rigid, I don't see there is any evidence of rigidity. You can see certain osteophytes on the lateral condyle. Once the osteophyte is released, you could have significant correction. And with this, when these epicondylar osteotomies are required, is one who doesn't dare to release adequately the posterolateral corner. If you release adequately the posterolateral corner, you should be able to balance the knee without an epicondylar osteotomy in a type 2. Whereas epicondylar osteotomies are reserved when you have a flexion deformity, a completely rigid valgus, non-correctable valgus, with already some amount of hardware on the lateral side of the tibia or the femur, may be an indication for a stiff valgus knee may require an epicondylar osteotomy and sliding down. Whereas this type 2 valgus, I personally feel is just with a normal routine PS implant with an adequate lateral or a posterolateral corner release, you should be able to balance the knee. This is my opinion. Another thing is that in such kind of a valgus knee, I would go contrary to Dr. Rajkana, is that I would always gap balance these knees rather than measured resection these knees. Anyone want to take on this?
Yeah, epicondylar osteotomy, to summarize, when the MCL is so much stressed, which is much more than what we see in this case, we do epicondylar osteotomy. In here, it is minimally stretched. It's not too much stretched. So that is why we all agree that at least most of them agree that epicondylar osteotomy is not necessary. Another thing is
you could see the lateral on the femoral side. You can see a significant amount of osteophytes overhanging on the lateral femur, and also on the once those osteophytes are removed, automatically the correction will happen.
True, sir. In this case, it might not be necessary.
Yeah, this case I'm not talking about epicondylar osteotomy. I am talking about in fixed rigid cases. I would not be going and doing step-by-step release of soft tissue. I would take it out as a whole. In this case, I don't think it will be released. I would even come out with a CR. I won't even be going with a PS knee here. So because I am now 98% CR surgeon, so I won't even be thinking about PS here. So this is pretty straightforward as far as the valgus is concerned.
Yes.
Keep the knee
regarding this,
Dr.
Rajkana, regarding this gap balancing or the measured resection in valgus knees, what takes on others can take on it?
See, in a valgus knee, the lateral side is tight. So if you are going to put the femur parallel to tibia, you are going to internal rotate the femur with respect to the transepicondylar axis. Then you are internally rotating the femur. See, a few degree of internal rotation has no harm. Few degree meaning even 3 degree or 4 degree, it's fine. But when it goes to 5 degree, 7 degree, more than that, then it becomes a problem for patellar tracking. That is why we don't internal rotate too much. We have to consider transepicondylar axis.
That is all. We just have to consider transepicondylar axis, but we don't.
That doesn't mean to rotate completely to beyond the transepicondylar.
If you're taking the transepicondylar axis, you are still externally rotating roughly by around 3 degrees. Maybe
sir, when we say gap balance, sir, when we balance, it also includes the soft tissue release also are included in it. The remaining part of the rotation is taken by the soft tissue release.
No, when I am telling, we don't vehemently internally rotate and consider transepicondylar axis. When I am telling that we are limiting the internal rotation, I am indirectly telling that we are considering measured resection technique or even a hybrid technique. It's not a pure gap balancing technique. That is what I am telling.
It is. I agree with that, but it cannot be just pure measure resection. We never without releasing once.
For discussion sake, we are just talking theory, but practically, if you see, you internally rotate and the patellar tracking will be superb. You have kept in external rotation and patellar tracking will still may not be good. That happens on table, but I'm just talking theory here, how we should approach. But practically, so many things differ when we do the case on table.
Might be your meaning like kinematic alignment, the knee patella will maltrack if you keep it in the same axis like that, sir.
The question is for whom?
Sir, I will do this without any release, without any external rotation, kinematic with mobile bearing with buccal purpose. I have done more severe cases like this in Madurai as a live demonstration last year, last June. It came out very well. No release, no external rotation, only gap balancing. First, establish the flexion gap, then the extension gap. Everything becomes all right. It's as simple as that. No damage to any soft tissue.
Sir, what is your final alignment axis, sir?
Alignment, we don't come hip, knee, ankle axis need not be zero as per kinematic alignment.
So you are just leaving it in whatever axis it is.
No, we will reduce to some extent. Restricted kinematic alignment, not the complete unrestricted kinematic alignment. So you take roughly about 3 degrees of varus cut in the tibia. So you take more on the medial side and less on the lateral side, just like a mechanical axis cut. In buccal power system, you have the gap positioner. You put in and see that whether it is correct or not. Even before cutting, you can balance it. If it is balance is good, you can continue. Otherwise, make a minimal release. So it is as simple as anything.
Sir, you
I have
mean to
done
know
more
that
than 20 of such cases.
after surgery, the knee will look more or less straight. It doesn't look in valgus. That is what you are telling.
Not excess valgus will be reduced to valgus. That is the principle of kinematic alignment. Restricted
Normal
kinematic
valgus.
alignment.
Anatomical valgus will be there.
Sir,
It will not
kinematic.
be completely kinematic. It will not be completely straight looking like all you release everything and make it straight cuts, 90 degrees cuts. Patient will be extremely happy. No, there won't be any pain. Third day you can discharge the patient. Definitely, if you don't touch the ligaments, they recover very fast.
Okay, Tarun, can you proceed?
Can you proceed?
Sure, sir. Sure, sir. So these were the lab values, and this was the pre-op checklist, sir. So definitely this case didn't need a lateral epicondyle osteotomy, but all the implants were kept in place just in case if it goes. So these were the thought process. Didn't want to take too much of tibial resection, wanted to do a varus cut, didn't want to increase the slope much. The valgus cut, reduce it to 3 degrees, and the distal femur cut, keep it minimal so that the extension gap doesn't increase. This was the treatment plan. So I had gone with the medial parapatellar arthrotomy, released the soft tissue. The same things were done. The sclerotic part was seen. The PLC alone was slightly released in order to see the rim of the tibia, and that made sure that I think, as your Bharat sir had said, had come out with just a PS knee with very little release that was required. Just that the patella was a bit more tight, and I had to give some pie crusting, which was very minimal. And these were the X-rays, which was post-operatively. This is the long length film, sir.
Ultimately,
Excellent job, Tarun.
Mithun, ultimately you did release some soft tissue or not?
So I actually didn't have to release much. Only the PLC corner, in order to see the tibia, I had to release, sir. Once I released the ITB in the front a bit, so it was all very, very minimal.
So you
can
released
see
the IT band.
everything was in the rim, sir. Not like a complete release at all. You can see what I've released. It's all in order to just see the tibial plate. It wasn't like complete release at all. It just sat in the way it was.
Rigid, na? So something has to be released.
Yeah.
No?
So what was the reason I felt is that the tibial condyle articulating with the femur condyle. So the osteophyte must have been an intra-articular blockade rather
It's
than the
osteophyte.
tight tissue at all. Yeah, as I
Exactly.
said, it's the osteophyte. Exactly, sir. Just that preoperatively, I wasn't confident that that is the thing. That was why I was a bit very confused, because how the medial thing is going to come and sit was the issue, but it was the osteophyte which was the issue, because the MCL was solid and everything was fine otherwise. So it was just the osteophyte and not the tight tissue at all. The only release that I had to do was a pie crust.
No, you told you released the IT band, right?
So I not a complete release. As I said, it was just a tease of the, just in order to keep a
Okay.
homens
My,
or
my
something.
perspective is we
Yeah.
should not underestimate the IT band, because most of the
Okay.
time you release the tight part of the IT band, the deformity gets corrected.
Okay.
So we should not overlook IT band at all. First of
Okay.
all, what has to come to our mind is IT band. Then only the
Okay.
soft tissue in and around the knee, because IT
Okay.
band contributes than what more we think.
Okay. So others take on it, sir. First, in case this was more rigid, would you first go and release the IT band or any other structures, sir? Just to get a.
No, you check it intraoperatively. If the IT band is tight, you release it. You check, you palpate, and
Okay.
see. You put a tension laminar spreader.
Yeah.
You have to
That
check
was
the
used.
structures. Yeah, whichever is
Yeah.
tight, you just release it. Very simple.
Okay.
Tarun, why did you put a stem for the tibia?
So very osteoporotic, sir. So had it in with me, and I thought it's wiser to put it because the tibial side was very weak.
Yeah, you could have had a shorter stem, might be.
Might be I could have used a
அப்படியா
shorter, sir.
வாழ்க்கை
This is slightly longer and stubby, yes, sir. This preoperatively also very osteopenic, so that's why the stems are no other
So the
reason.
nerve was intact, luckily.
Nerve was intact, all fine, sir. Just that,
Okay.
yeah. Thank you, sir.
Tarun,
Nice
Yes, sir.
tip, Tarun.
Yes, sir.
you're used to
Thank
Smith
you.
and Nephew.
Yes, sir.
The Smith and Nephew keel, the tibial keel is already quite longer.
Yes.
Okay.
Oh, yes.
So for
That's
this
true.
kind of case, this is my
Not
opinion.
needed.
For this,
Okay, sir.
I from the tibial preparation, what you have shown with multiple
sir.
drill holes, that quality of bone is sufficient to go for a normal stem, not required. Until otherwise,
Okay,
you
sir.
have uneven
Point
surface
taken.
on the lateral side. You may require a long stem. Otherwise, you could go on with the normal tibial
Normal.
tray, because the Smith and Nephew Anthem have already a longer keel on it.
Yes. Point taken, sir. Sure. Next time.
There's a short cemented stem, 100 mm. If at all any tibial
100
defect, you can prefer it. Pretty
Yeah, actually, now looking back at yeah, thank you, sir.
Thanks, Arun. Okay,
Sure, sir.
thanks for the lovely presentation.